Hi guys, my name's Kat and I'm with 10 Minute Medicine today with a session on post-op delirium. Be sure to check out our YouTube channel and website for other videos about perioperative medicine for junior doctors. So, what is delirium? Delirium is defined as an acute fluctuating change in mental status with inattention, disorganized thinking, and altered levels of consciousness. So essentially, it's a change in your cognition, and arguably, after an anesthetic and sedation, you can expect a delirium in most people lasting maybe 30 minutes to an hour. However, we're talking about the delirium you see in someone when you're reviewing them a few days after an operation, which is unusual and which we often see in frailer patients. So, what's the incidence of post-op delirium? It affects approximately a quarter of hospital admissions and as many as 83% of people in ICU. You'll mostly be seeing people on the wards. So I'm going to talk quickly about the different types of delirium. So it can take a hyperactive form, which is, for example, aggressive behavior. Nurses telling you that a patient has pulled out their catheter and is behaving in quite an unusual way, or hypoactive, which is more difficult to spot. Someone will be quite lethargic or flat and not be able to pay attention to what you're saying to them. And both of these are types of delirium. So how do we assess delirium? Firstly, look at the notes from the patient and look at their previous imaging. If you can, gather a collateral from their family members or next of kin or someone that knows them well to find out what their baseline cognitive function is like. It could be that you've been escalated that someone's delirious, but they might be like that normally and they actually have dementia. Look at their past medical history. Have they had a stroke, previous delirium, or cognitive impairment, perhaps diagnosed in the community by the GP? And look at their social history. Particularly alcohol is important here. A lot of people can become delirious in hospital because they're actually in alcohol withdrawal. Look at what medications they use in the community, and is there evidence of illegal drug use, and are they frail? Frail people are more prone to get a delirium. In your assessment, you can do a cognitive assessment, such as an AMTS or a 4AT. And of course, a full examination of the patient is important. Perhaps you can find a localizing sign of something that could be causing their delirium. It's basically a top-to-toe examination, A to E, of finding something that could be wrong that we can fix and maybe improve the delirium. In terms of investigations, I've split them into bedside, bloods, and imaging to keep it nice and simple. Do a urinalysis or a urine MCS to rule out a UTI. However, it's important that you also think of other causes. A UTI is very common in older people, and a positive urine dipstick is not enough to diagnose the UTI as the cause of delirium in the elderly. So look for other signs. Do they have a raised white cell count or a fever or suprapubic tenderness? That also explains them having a UTI. And don't forget to look for other causes as well. You might have multiple things coming together that's causing a multifactorial delirium. The confusion screen might be an order set that already exists in your hospital. Make sure to refer to your local guidelines for this, but it usually includes a full blood count to look for anemias or raised white cells, looking at all the electrolytes, liver function tests, your clotting, thyroid function tests, B12 and folate. In terms of imaging, consider a chest x-ray. If you've had anything on your examination or there's evidence of a new increased oxygen requirement, or consider a CT head if you think there might be something intracranially going on that could cause the delirium. There's lots of differentials for delirium in a post-operative patient, and often the pinch me mnemonic is used in elderly, frail people to think about what could be causing the delirium. And as you can see, it's often things that aren't necessarily seen on blood tests. So it's really from reviewing the patient that you'll find out these things. Even pain is enough to cause delirium in an elderly post-op patient. So make sure that you assess their pain on your examination and review their pain relief. Infection we would spot on our examination, perhaps the urine MCS of blood cultures and our full blood count. Look at their nutrition. Have they been eating well post-operatively? Are they just really constipated? Lots of people are constipated post-op, and it's important to prescribe laxatives because, for example, if you're taking morphine post-operatively, that can really bung you up. Are they adequately hydrated? Lots of elderly people are not hydrated after an operation. Look at their medication. Is there any anticholinergic medication? Is there codeine or morphine? Has that had an influence on the delirium? And obviously, this is a bit of a balance, as you also want them to not be in pain. Think about their environment. They're in an unfamiliar hospital environment, which definitely contributes to delirium as well. Is there any way we can make them feel more at home? Other differentials are any metabolic disturbance. Are they actually post-ictal or have had a seizure? Are they in alcohol withdrawal, which we treat with a weaning chlordiazepoxide regimen and thiamine? Have they lost their hearing aids or lost their glasses? That's actually a very, very common thing you see in hospital. And it can be life-changing to put someone's hearing aids back in and then see their delirium magically resolve. Is there any other organ dysfunction? So liver, renal, and heart failure could be causing a delirium. In terms of management, there's lots of things you can do. So treating any organic causes we've found in our previous slide. So antibiotics for an infection, hearing aids back in. Reviewing their drug chart, rationalize opiates, benzodiazepines, and anticholinergic medications. Remember, these medications might need to be weaned slowly and would have adverse effects if you just suddenly stop them. So make sure to consult with your seniors or pharmacists about how best to stop them. Hearing aids and glasses are very important. Regular orientation to time, place, and person. Put a clock and a calendar or familiar objects next to the patient and encourage independence. So this will require you liaising with the healthcare assistants to let them know that this patient might require a bit of extra attention. Early mobilization and rehabilitation and post-op is really important in these patients and can really dramatically make a difference. Support their eating and drinking, so perhaps starting a food chart and making sure that the healthcare assistants help them with their eating and drinking, as in their mental state they will not be able to remember to eat and drink and not have the drive to do that. So it's important to keep them hydrated. You can use behaviour charts if there's particularly aggressive or unusual behaviour, so you can monitor what it's like overnight and perhaps involve the dementia teams in your hospital. Involve geriatricians, the med-reg or the perioperative medicine team if you have those in your hospital. This is shown to really improve outcomes on surgical wards. And lastly, make sure you keep patients safe by the least restrictive method. If you're getting bleeped with the nurses unable to manage a behaviour of the patient and asking you to consider sedation, make sure you try environmental de-escalation techniques first. And when you consider sedation, this would be the point at which you speak to a senior med-reg, geriatrician or old age psychiatrist who'd be able to help you safely sedate this patient. And these are my sources. Thank you very much, everyone.